So good morning, and dear Mr. Chairman, dear Franz, thanks for inviting me. I'm also a rookie to this meeting, and when I first got the topic on this lecture, I thought, well, the rookie gets the bone of the meal, but at least since histology is still the gold standard, it's a golden bone, and I will present you that there's also some meat on this bone. So when we're talking about histology, we're talking about the classical things we have heard during the days, and we were discussing a lot about. We have not very much talked about typing. We have talked a lot about grading and staging, and we will hear this morning in the following talk something about markers. But these are all things that influence our view and our therapeutic influence. So typing, when we see all the studies, there are only few that really deal with the typing. There are just some who address the tumor type and the outcomes, mostly from the Hopkins. All others say it's prostate cancer. That's it. We had a similar situation in lung cancer. When I remember when I was a young resident, that was so frustrating doing with lung cancers. So we did a lot of efforts in diagnosing these cancers and really proved that it's a primary lung cancer and typed it and whatever, and ended up at the clinicians as a non-small cell lung cancer, period. So that was really frustrating. And recent years, it completely changed. Now, the subtyping of the tumor is one of the important things that gives you the options for the therapy. So without typing of lung cancers, you can't plan a very good therapy for lung cancers anymore. So, and I hope that we need more studies on this issue as well. So when we're looking at typing what exists, so we are mostly talking about acinar adenocarcinoma. But as I see on the microscope every day, not cancer is just cancer. I can say every man really has his own cancer and has his own way we look at. So we have really atrophic cancers, pseudohypoplastic, foamy, mucinous cancers, signal ring cancers, oncocytic, and even lymphoepithelioma-like tumors, which we know from the ORL tumors. So one might say, okay, this guy is sitting in the microscope at his basement looking at fancy pictures and having great fun doing all this stuff. You know, of course, this is important to recognize this tumor entity because to give the right diagnosis. Otherwise, one would say, if you have a mucinous tumor, is that a prostate cancer at all? Or is it a metastasis or anything fancy occurring in the prostate? So to give you an impression how cancer looks like, and we're really looking the cancer straight in the eyes, you know, this looks completely different than this one, which really looks like a hyperplastic nodule, and this really foamy looks like also like in malakoplakia, so which can easily be misdiagnosed. And this really looks like a mucinous cancer from the rectum, and this could be from the stomach, and this also oncocytic could be from the kidney. But these are all proven prostate cancers. And everybody with you will agree, if we do a study, you know, mixing this tumor with this tumor and this tumor and this tumor, I'm not really surprised that you may get different results. So we also know non-acinar adenocarcinomas that occur in 5 to 10%. Which is pretty low, but still it's there. And we ever see the mixed tumors, the sarcomatoid carcinomas, the ductal adenocarcinomas, which you are pretty familiar with. We have also squamous and mixed adenosquamous carcinomas, of course infiltrating or primary urothelial carcinomas, also the rare small cell and basal cell carcinomas, and also clear cell adenocarcinomas. So, and also here give you an impression, probably this one is the most you are familiar with, the ductal carcinoma, and the urothelial carcinoma, which rarely you might find in your diagnosis. And the sarcomatoid, I will really emphasize, these are two components that are pretty much important. As we know from the gynecological cancers, where carcinosarcoma also occurs, we know mostly the epithelial part is the one that metastasizes, but sometimes it does not. So once we have the cases of a sarcomatoid carcinoma in the prostate, and the patient shows up with metastasis, one might argue, of course, this is a metastasis from this prostate cancer, but how the hell do you know what part has metastasized? Is that the epithelial part, or is that the sarcomatous part? So I never get tired in these conferences to get any physician to peek a needle in there or get a biopsy out to see what part of the tumor had metastasized. If this is the epithelial part, your options are completely different if the sarcomatous site has metastasized. So you should be aware of, and also small cell carcinoma is the one you don't want to really operate on because these guys run really poor, and you should treat it like you treat the small cell carcinomas of the lung. So since 2004, we know even new variants of prostate cancer. We have this microcystic adenocarcinoma, which has been reported by Humphrey recently. We have a carcinoma that looks like a pin. We have a neuroendocrine carcinoma that resembles the one in the lung, the large cell. And we have a giant cell adenocarcinoma, which you want to see here. That is the microcystic that also resembles the hypoplastic condition. And we have this one that looks like a pin, but if you recognize here is the nerve sheath. So this infiltrates the nerves, so this is not a pin. And this one, the large cell, the large cell, here we go. The large cell neuroendocrine, which has a very aggressive tumor, and the giant cell, as you may really see, this is a nicely pictured once you see it in the microscope. So, what is the clinical relevance? As I mentioned, the subtype gives you some information which are the bad guys, and which are the ones we can really treat as conventional prostate cancers, as you all know. So these are the really bad ones. This is the signet ring, the lymphoepithelioma-like, the sarcomatoid, the ductal, the squamous and adenosquamous, the small cell, of course, and the neuroendocrine large cell, and the pleomorphic giant cell. So my plea is, look at your reports. In your histology report, you should find the term of the typing. It's unsatisfactory to write prostate cancer PT2A. This is not okay. There should be acinar adenocarcinoma. So this gives you the right type, or it's a subtype of that. So we had heard a lot of grading, and grading has tremendous changes after a long time of really nothing. So in 1966, that was introduced by Donald Gleason, and we were all, like in the mid-centuries, we were addicted to this one system, and nobody ever had the courage to really question that in any part. So unfortunately, he passed away in 2008, and obviously that was the time when the community thought, well, let's think about this grading. And in 2005, the first attempts were made, but as you see, there was not much. You know, we were talking at that point about the cribriform lesions that were included here, which were mostly diagnosed as Gleason 4 right now, is in the former versions included in the pattern 3, and that was the reason in the early days we were all low graders. So you always had these 2+2, 2+3, 3+2, and you rarely had those high-grade tumors. But after this, you know, the community thought, well, that really doesn't make sense. So many very good differentiated tumors and so poor outcomes, that can't be right. And Gleason had a respectable amount of 1+1 cancers. In 2005, nobody really diagnoses a 1+1 cancer. In fact, when you look at the pictures in the textbooks, in the old textbooks, you see a picture of a 1.1 Gleason cancer, and look at a later textbook, you see the same picture, and it's got a Gleason score 1+2, and you look at another later textbook, you see exactly the same picture, it's got already a 2+2 or 2+1. So things change, and it's all man-made, and we should keep this in mind. And if you look here, after like 40 years, nothing happened. Like within 5 years, another thing happened. You know, as you see, this is the original publication from Epstein and colleagues for the Consensus Conference in 2005, and now the new Bible of the pathologists, the Atlas of Tumor Pathology from the Armed Forces Institute of Pathology came out, and as you see, somebody photoshopped this. You see this one here, which was also acknowledged as Gleason pattern 3, that was taken out, and that one dropped here. See, this one taken out, and they dropped it just here. So the message here is the community is taught, don't do a low grading, become high graders, and that is what we see now, and I'll get back to this in a minute. So what happened? Changes in pattern 1 and 3. So Gleason 1+1, no one really does it. If you ever get such a diagnosis, really question this diagnosis. And in biopsies at 2 until 4, or 2+2, or 2+1, 1+2, whatever, no, it's unacceptable. It's unacceptable. Poor reproducibility, poor correlation with prostatectomy grade. The edge can really seen in the biopsies to judge this this Gleason score, and it misguides you actually. You think this is some kind of insignificant cancer, and really it's not. So what happened in 1991? We had, as I said, 24% Gleason scores 2 to 4. In 2001, already 2.4. In 2008, 0%. Nobody really does that anymore. So in Patterson 3, what happened now? Individual cells, as accepted earlier, would not be allowed anymore in Gleason pattern 3. That changed to Gleason pattern 4. And the vast majority of cribriform patterns are diagnosed as a 4 pattern, with only rare cribriform lesions satisfying with the pattern 3. But this is already, has been photoshopped, so nobody really accepts cribriform structures as a Gleason pattern 3 anymore. So what happens? Gleason score 5 decreased from 12.2% to 0.3%. The 6, as you all noticed, from almost 50% to 20%. And Gleason score 7, of course, increased to the majority. And that's the reason why we're looking at, and I think the next is up at the horizon. So a pathology community questions the Gleason pattern 5, and first papers are out that Gleason pattern 5 is pretty much underdiagnosed. So we're really confronting the community with more upgrading. So be prepared that your reports will have increasing Gleason scores. So effects after modification. So Gleason 2 to 4 is almost gone. Gleason 5, rarely, if ever. Then limiting definition of Gleason pattern 3 really constricts these tumors to a rare population, and then we can really talk about insignificant cancer. And the effect among the pathological societies, we have a better agreement between the Gleason scores in needle biopsy and radical prostatectomy, and a better inter-observer reproducibility. So diagnosis that is made really becomes better. And be careful in using old reports before that time. You really can't do that anymore. So what you do is we are trying to set up a really reproducible setting or definition. And we had a group from the working group of uropathology, the European working group, and we had a meeting, a consensus meeting, where we set up really consensus cases for the Gleason pattern 3 and 4 in order to define and to give recommendations when to diagnose what pattern in what manner. And so we sat together and defined these subtypes, which are illustrated here, and gave a tool. And we had a nice survey on this in the pathological community. And as it turned out, the pathological community was taught by us, don't do that low grading anymore. And the result was they are all high graders. So even the clear 3+3 cases came back by a certain amount of pathologists, urology interested pathologists, as 3+4 or 4+3. So we still need better definitions. What pattern is the predominant, and what are the characteristics for what pattern? So this group, this is one paper, and the one will be coming out soon. So talking about staging is pretty frustrating for pathologists. So we had this 5th edition in 2002, which was I think, appropriate. In 2007, that came out. That was pretty frustrating. In the 7th edition, they announced it as the big throw in prostate cancer. From a pathologist's view, that was pretty frustrating. So, well, the one thing was Gleason score was the preferred grading system. Well, thank you. Bladder neck invasion, PT3A, that was a great thing. That was a great thing. So all the PT4s dropped out. So, and the PSA, including stage grouping, that is interesting for clinicians, but not for pathologists. That's about it. The big problems we addressed remained open. So, as you all know, PT2 tumors rarely exist. PT2B, as you know, more than 1/2 of one lobe, but not the other lobe. So if you gain, or if you imagine you have a 35-gram prostate, more than half of one lobe would reflect about 8 cubic centimeter tumor, and one can hardly imagine that such a large tumor should be unifocal on one side. So that was a poor corresponding between clinical and pathological staging, only 36%, that's not satisfactory. And also the uni-multifocality failed to predict biochemical recurrence. So what the hell are we doing here? But excellent correlation between tumor size and tumor volume, but you know, that is not really reflected in the TNM classification. So why are we sitting here with our residents saying, what is it, do A, B, C? It's all bullshit. As I see all your studies, you're talking about PT2 tumors. You say clinically or locally advanced or organ confined or whatever. So nobody really gives a damn on this PTA, B, C. So why the hell are we keeping on holding this up? So looking at some facts. Majority of cases with maximum tumor diameter below 5 millimeter have a tumor volume of less than 0.5 cubic centimeter, as we've heard the other days. And the volume below 0.5 cubic centimeters in Gleason score 7 have an excellent prognosis, as you all know. That's the one part of the definition for insignificant tumor. And each centimeter increase with the maximum tumor diameter is associated with a 70% increase in risk of recurrence. And from a large study from Cheng, from the Stanford group, had shown that the medium of the maximum tumor diameter is 16 millimeters. So we have been talking about index tumors, and that's a pretty smart discussion. So we're talking about multifocality, but we're also talking about tumor size. And why has nobody ever thought about using the size within the stage grouping? So that's why they came. So this is the old one, the bullshit one, and this is the proposed one. So they say PT2A, largest tumor less than 5 millimeter, largest tumor, of course. The PT2B, largest tumor above 5 and below 16, and 2C, largest tumor 16 millimeter. That sounds really smart, doesn't it? Objection, objection, not so fast, not so fast. This is a proposal, so that sounds very easy, but there are some issues we need to address, as you see here. Now, this is an example for a prostate. There's this one tumor, Gleason score 5, 3 plus 2, and this tiny tumor, Gleason score 6, 3 plus 3. If we go for the index tumor, so this tiny tumor would be our index tumor, and we would like to do an overall score of a 3 plus 2, if you think. So, looking at this one, excuse me, this could also pretty easy. This is the large index tumor, which is a low grader. This is the smaller tumor, which is a higher grader. So one could also think that my index tumor is this one. So what about this one here? This is the largest, the low grade, the transitional zone tumor, which probably is a very indolent tumor, which has been lasted for years. And there's this other one, small tumor, which is a high-grade tumor, which is in the posterior zone, and at least in this sketch, is extraprostatic. So what is our index tumor? According to this definition I showed you before, this would be our index tumor. Yeah, so it's not so smart as it looks. So we have been addressing this system at a consensus conference in 2009 on staging and handling, and we were voting on the delegates and asked, so what should we do? What is the index tumor? Should we use the largest tumor? 24% yes. Size and grade, 30% yes. Stage and grade, 28% yes. So you see, pathological society is split in third, and I think you might be as well. So which should we do? I think I agree I would use this one because this is stage relevant and probably really biological relevant. So, but who gives me the thing that this one and this one should be even, or this one is worse than this one? So further studies are really needed on this point before we go into this next classification. But the turnaround time is about 7-8 years, so it came out by 2010, so we have still some time left. So to address this issue, we gave an overview and a sketch of the prostate cancer diagnosis. We give you a little impression of how the tumor is distributed throughout the prostate, and together with the measurements, you may have an overview of how to treat your patient and what the most likely prognostic value can be. So I could stop here if I'm over time. Thank you.
Thank you very much. Well, thank you for this excellent talk. I have just a question. In the beginning of your talk, you showed the different histological subtypes. Do you have to remove the prostate to get the diagnosis, or can this be diagnosed based on the needle biopsy?
Yeah, you can do it on needle biopsy.
Okay. Yep. Yes, Gerald.
So what is the current transatlantic definition of the Gleason score at a radical prostatectomy?
In terms of?
Commonest pattern worst, commonest second commonest with a tertiary. What is the preferred?
In the radical, we use the commonest and the second and give also the tertiary in a comment. Well, we do that in our sketch just by ticking the boxes, all present scores. Well, you should have in your report the score, the first, the second, and if present, the tertiary score.
Okay, there was a question, yes.
I think we will come in trouble with our Epstein criteria for active surveillance. When we now have more Gleason 4, then we have a less amount for these candidates, or?
Yeah, that's right. Also, the people from the brachytherapy, they have their indications as a 3+3 mostly. And as you see, that rapidly decreased the 3+3 tumors, less patients fulfill the criteria for brachytherapy then. That's right. Yeah.
From a patient perspective, we're always now looking at a 6 on a scale of 10, and patients are always worried about this is pretty high up. Shouldn't we change the Gleason grading and re-skew it again a little bit and change the numbers?
Well, according to me, nobody really had the balls to cut those 1 and 2 patterns, so we're facing it maybe in the future.
Okay. Thank you very much.
Okay, thank you.